Hello, today we're going to be talking about head, brain, face, and neck trauma. We are going to kind of focus in on head and brain issues in this particular lecture. So just a quick overview of the anatomy of the skull. You have the skull that is part of the skeletal system. It's obviously for protection of the brain. It's called the cranium. It is composed of various plates that are fused together. They are fused together after birth. So when you do have that premature, the preemie babies, infants up to about a year, are not fully fused, so that could cause some issues in relation to that. But that is beyond the scope of this particular lecture. Your facial bones make up the front part of that skull. So you have the orbits, the nose, the maxilla, the zygomatic bones, and the mandible. Your basilar skull is the floor of the skull, and one way, the easy way to remember it is the base of the skull. So you can think of it that way. Your brain actually occupies about 85% of the total space within the skull. The remainder of the space is cerebral spinal fluid and blood volume. So you have 15% between the CSF and blood. So here is a illustration of the brain and the cranial vault. So in this particular slide, I'd like for you to pay attention to the layers here. So at the very top, you have the cranium, the actual bone. Outside of that, you do have the skin itself and all the tissues associated with the skin. Just below the cranium, you have the dura mater. You do have a space between the dura mater and the cranium that is important as well. Right below the dura mater, you have the arachnoid membrane. And then below that, you have the pia mater, which is basically a covering of the brain. And then you have the brain itself. And we're not going to get into the various parts of the brain in this lecture. So the cerebral spinal fluid serves as a cushion for the brain. It bathes the brain. It provides nutrition for the brain. It is what just helps to protect it. It kind of, in a way, is like floating in water. So it offers that type of a protection. It is surrounded by 3 layers of meninges. There are the different parts of the brain as well we talked about. Again, I'm not going to go into all the functions of these. The other lecture associated with this, I went into a little more detail. So that is addressed with all of that. So the neck, just a quick overview, the neck is the structure that is visible. It supports the head, contains the trachea, the larynx. It is vital, obviously, to air exchange. It is vital for transporting blood to and from the brain. So there are many significant parts of the anatomy of the neck that are important that we need to be aware of and understand thoroughly the importance and significance when it comes to neck related issues. General management that we're going to look at here is altered mental status, some bleeding, some substantial edema, and discoloration. So complaints that we will a lot of times get when it comes to the head is going to be pain. You're going to have swelling in obviously the affected area. You may have loss of function due to what area is affected as well. And the function that is lost will be dependent upon the area of the brain that is affected a lot of times. You may have dizziness, then you have headaches, nausea, and vomiting that all can originate as complaints from head issues. So we're obviously going to make sure we do a proper scene size up, check for safety, mechanism of injury. one thing that is important with these patients, as with all patients, sometimes when you get to a patient that has a head injury, the injury itself can be grotesque. It could be very um, just overwhelming. It could present as something you're not quite expecting. We have to be careful not to let that um, be displayed to the patient, because it can really cause increased anxiety and increased issues that you will then have to deal with. So we got to make sure that we don't get distracted by these injuries. And these injuries can also bleed a lot, um, and cause some significant um, distractions if we're not careful. We do always want to make sure we maintain a good open airway, ventilations, oxygenation, and adequate circulation. Um, Anytime you're dealing with the neck and the face area with issues, you're always going to have that risk of aspiration. You're going to have risk of swelling, of obstruction. And so all those things need to be kept in mind, need to be reassessed frequently as needed. In severe cases, we may have to control the airway with endotracheal intubation and possibly cricothyrotomy. That's beyond the scope of this presentation as well, so we'll leave that where it lies. Um, these patients, a lot of time, this presentation is written for across the country, so there's not always paramedics available. So in the case that there's not, you always want to make sure that you have a paramedic available if you need it, or you need to be getting to the closest ER as soon as possible when it comes to airway issues. Even medics may need to go to the closest hospital when it comes to airway issues. We always want to make sure we have our vital signs, our sample history. We got to get our baseline for that patient, um, so we can have that to compare to and to trend. Any critical patient gets vitals and assessments every 5 minutes. Non-critical patients, we're going to about 15 minutes for assessments and vital signs. And one of the easiest things that you can do for this is set the monitor up to do that for you. It will automatically do your blood pressures and create a vital sign history every 5 minutes, every 10, every 15, as you whatever it's programmed to. And you can change that. We're always going to be alert for signs and symptoms of shock as well, with all these patients. So uh, you have injuries to the head. So you can have your closed scalp injuries that occur from blunt trauma, a trip, a fall, an assault, whatever. Anytime you have that blunt trauma, you get those closed scalp injuries. You may even get a open scalp injury as a result of some of these. Um, but this is where you're going to have that hematoma, that big old goose egg on the head. It's really good to, if you go back to that anatomy we were talking about earlier, is to knowing what is underlying that particular area when it comes to the cranial bones and also to the parts of the brain, because you may have effects that will extend beyond just the surface, depending on um, a lot of the mechanics and forces that might be applicable to that particular impact. A lot of times these superficial type things are very easily managed with cold packs. If there's bleeding, it will help that externally. It will also help that internally, because as we know, a lot of hematomas are actually caused by bleeding under the skin. So that cold pack can help to constrict that, the arteries, the vessels that are involved, to help reduce that blood flow under the skin. Again, knowing that anatomy is important, because there are parts of the brain or the head that have arteries that are prone to bleeding, causing issues. So types of skull fractures here. We have the linear non-displaced. You can think of that as just a crack. You have the depressed, so you obviously have a depression associated with that. You have an open, where you actually have bone missing, or displaced, dislodged. And then you have the impaled object. We typically don't see that one a lot, but it is not out of the question. We have to remember that with brain injuries, the skull does not expand. So any swelling or any change within the brain itself, the cerebral spinal fluid, and the blood that is in the cranial vault will alter the intracranial pressure. And any alteration in the intracranial pressure can be significant and impact the morbidity and mortality of the patient. So we can have a primary brain injury, which is the actual time of the impact of the skull. That is when they get hit, when they get that injury occurs. A secondary brain injury is going to be a result of swelling and increased intracranial pressure or bleeding or anything else that goes on as a result of that primary injury. So we're concerned about the ischemia, the hypoxia, and the cerebral edema. So your cerebral edema and increased intracranial pressure, um, again, as brain tissue compresses by the increased intracranial pressure, you're going to have dysfunction of that brain in the parts that are being compressed. The compression can cause decreased blood flow. It causes irritation. It causes the inability of the brain to function properly in a lot of ways. Because of this, you can get projectile vomiting. You can have severe headaches. It's uncontrollable. You get altered mental status as well. Pupils can become unequal due to this increased intracranial pressure. Cushing's reflex is increased blood pressure. The reason you have increased blood pressure is to try to compensate because of the increased intracranial pressure from swelling. The increased blood pressure actually can add to that pressure, but it is an effort to distribute blood to the brain where it is needed. Another part of Cushing's reflex is decreased heart rate. As a result of the pressure on the primary parts of the brain with the medulla, the pons, and all those areas, then those areas are responsible for your heartbeat. And because of that pressure, it causes your heart rate to slow down and to not function properly and response the way that it should. And then when you get to this Cushing's triad, you have Cushing's reflex, plus you have the irregular breathing pattern. And again, that is due to that compression on the brainstem, the medulla, the pons, and those primitive areas of the brain that control these primary functions of the body. So Cushing's triad is a really good indication of increased intracranial pressure. So with the cerebral edema and increased intracranial pressure, the pressure is worsened with intracranial bleeding and cerebral edema. Obviously, we've already talked about that. But how do we correct that? The only correction really that can be made is surgical interventions and some medications. It depends on the severity, it depends on the location, and what exactly is going on with that patient. So quick recognition, quick transportation to the appropriate hospital, and the only two appropriate hospitals in our area are Grady and Atlanta Medical Center. Now, one of the things that we don't want to occur, but we need to be familiar with is this herniation. So as the swelling increases, as the intracranial pressure increases, that vault is fixed. It will not change. But there is one place that there is a hole in the vault, and that is where the spinal cord comes up through the foramen magnum into the cranial vault. And so with this pressure, the brain is actually forced and will herniate down through that opening, causing death. And this is also why we are seeing Cushing's triad, because those portions of the brain that are right there um, are responsible for those manifestations that we see. So you have Cushing's triad, you have pupillary changes, you have altered respirations, you have trismus, which is locked jaw, and then you have the posturing in response to painful stimuli. So that's when you get to that decorticate, that decerebral posturing, because of those pressures in those areas of the brain. So the decorticate posturing is the rigid extension of the extremities in response to painful stimuli, whereas your decorticate posturing is rigid flexion of the upper extremities in response to painful stimuli. So the cerebral posturing is extension out. So it would be like a big stretch of your arms and your legs and just everything all stretched out. Decorticate is where your arms will draw in towards your body, um, and become rigid that way. Mean arterial pressure. Mean arterial pressure is hugely important, um, when we're looking at perfusion to the brain, especially with brain injuries. So the map, um, is what we talk about when we're talking about that cerebral perfusion. So patients with a TBI should receive IV fluids to maintain a systolic pressure of 90. Um, you really that is a good starting point, but it's more important to look at the map, um, that the monitor will provide for you, or you can calculate it to maintain that perfusion. And you need to have a map of 60. So if you go by systolic blood pressure, you're looking at a systolic of 90. If you're going by map, you need to look at a map of at least 60. We want to ventilate this patient to remove excess carbon dioxide. We're not looking at super hyperventilation. Anybody that's been in EMS for a while remembers hyperventilation is, one breath every second. That's way too much. We're only looking at slight hyperventilation, and this should be driven by your end-tidal CO2. So when we have this patient on end-tidal CO2, and we're hyperventilating this patient, we're wanting that end-tidal CO2 number to be about 35. We're not looking to get that down into the 20s, into the low 30s. We're looking more of a passive hypoventilation. And the reason we do that is because when you have high CO2, you cause vasodilation, which causes increased intracranial pressure. If you get the CO2 too low, you get vasoconstriction, which constricts and restricts blood flow to the brain, which will cause an increase in your blood pressure. So we're looking to keep that on the low end of normal, to help fight off any issues or any contributions, to that increased intracranial pressure associated with blood volume and blood circulation. So we're going to increase that brain, and we're going to monitor that blood glucose level, so that the brain can function properly. Um, when we talk about the blood glucose level, it's really important that we're not, um, giving them too much. Glucose is a large particle. Um, it's a hyperosmolar medication that we give. We're not looking to alter, and cause third spacing of any kind or pull. We don't want to pull fluid here or there. So we want to maintain that blood glucose level, optimally is going to be between the 70 and 100. So if you have to give glucose to somebody with a head injury, we're not giving them a full amp. We're not giving them a half an amp. We're going to give them what they need in order to be normalized, but not hyper. So our key components of this neurological exam, we're obviously looking for altered mental status. We're looking for loss of consciousness after injuries. Is it transient? Is it a permanent? Is it ongoing? What exactly is going on with this loss of consciousness, that they have had or are currently experiencing? Um, we're looking at their mental status, the AVPU score. Um, we're looking at their pupils for size, for equality, for reaction to light. Will tell a lot of information about the patient. We're looking for any neurological defects. So, in a way, you're really doing, a stroke exam on a head injury patient because they can display some of the same type symptoms. So the only way to evaluate that is to basically do the same neurological exam as you do on a stroke patient. When you do a full stroke exam on a patient, you're looking and you're evaluating all the cranial nerves. And so there are 12 cranial nerves, and we're not going to go into all of the different cranial nerves and all of the different tests that you can do. But as you evaluate these areas of the body, that's what you're looking at, is to see how the brain, how that neurological part is working and where deficits are. Obviously, with any head injury, we're going to restrict cervical spine motion. We're going to use a C-collar. We're going to immobilize that patient. We have to maintain open and secure airway, ensure normal ventilation, administer oxygen as appropriate. Um, we're not going to hyperoxygenate these patients. As a rule, we're going to control any bleeding that this patient may have, as with any patient. We're going to start IVs. It says if needed, but I would recommend that you always have an IV with a traumatic brain injured patient. But I would not recommend that you bolus them with lots of fluid. Fluid should be used to maintain MAP and blood pressure, and to administer necessary medication. We want to maintain normal body temperature. With these patients, a lot of time, our trauma patients, they have to be disrobed. We need to make sure that we cover them. They need to be covered from really from head to toe because you can lose heat everywhere, especially with a brain injured patient. Um, they can lose their own ability to regulate their body temperature. So we need to make sure that we control that for them with blankets, with warm fluids, with whatever it is that we need to do to help maintain that. Checking that temperature um, on your reevaluations is a good thing. Making sure that we're not getting this patient hypothermic, because along with hypothermia comes a lot of issues in and of itself when it comes to metabolism and acidosis, and it's just not good. There are studies that prove that, especially with low blood pressure and hypothermia, the outcomes of trauma patients um, exponentially get worse. So we need to maintain blood pressure. We need to maintain um, normothermia. We've already talked about the treatment of hypoglycemia. These patients need to be transported without delay to the appropriate medical facility, which in our area is going to be Grady or Atlanta Medical Center. So now we're going to look at some specific brain injuries, starting with concussions. So a concussion is a brain injury caused by blunt force. There's no structural damage, but you can think of it more or less as like a bruise to the brain. You have the, as we'll see in the next slide, so the coup contra coup forces, the brain, the head is impacted, the brain then impacts the inside of the skull. It causes the irritation. It causes bruising to those tissues, which causes headaches, memory problems, depression, depending upon the area of the brain actually involved. Uh, you can have concussions in association with traumatic brain injuries, or you can have just some standalone concussions at various levels. So here's the illustration of that coup, contra coup um, forces that are applied with the brain swishing back and forth. The arteries, the vessels that are feeding the brain are somewhat fixed through that subarachnoid membrane as it comes in. So they will kind of move and swing back and forth, but they do have the potential, especially as people get older, um, to tear, to become ruptured and cause problems. But with the concussions, it's more or less just that brain impacting, um, causing that irritation that will heal. So now the cerebral contusion really is a bruise to the brain. You can have loss of consciousness with these, confusion, You can have some swelling to the brain, is always a concern. Um, and again, it's usually from that coup contra coup injury. So you could have an injury to the front, to the back, to either side, again, depending on how that impact occurs as the brain bounces around. So signs and symptoms of a traumatic brain injury: you have the altered mental status, weakness, seizures, altered respiratory patterns, which is an indication of a significant traumatic brain injury, bradycardia, hypertension, as we discussed earlier, impaired speech if they are conscious, unusual behavior, unequal pupils, nausea, vomiting, posturing, and trismus. So a diffuse axonal injury, just looking through my notes real quick. The diffuse axonal injuries can be very significant to people. They're caused by shearing or tearing forces associated with the acceleration, deceleration injuries. So as the brain bounces back and forth, if it twists any or whatever, those forces applied to that brain causes the neurons, the dendrites, and the those neural cells to be torn apart, to be twisted, to be disrupted, and that's called axonal injury. And diffuse obviously means in various places. So depending on the forces, the amount of forces, and everything that's going on with this, the prognosis for these injuries are generally poor. An example would be a shaken baby syndrome, where that all that force is just shaken out. And if you think of a bowl of Jello or something, and you just forcefully shake it, it's going to disrupt it. It's going to tear it. It's going to cause issues there. And the same thing is really going on in the brain. Um, Epidural hematomas associated a lot of times with linear fractures, and it's a lot of times associated with that middle meningeal artery. So you're looking at that temporal lobe, that temporal area, just right above, right in front of the ear. Um, you can see these with any impact to that area, but sports, baseball, softball, things like that are really big um, for that. An assault where someone is struck in that part of the head, you can get that middle meningeal artery, which can cause that subdural hematoma. And so as we look at this, we can see in this area here is this subdural hematoma. So this is outside of the dura mater, which is here, and inside of the skull, which is here. And the way that we can tell this on an x-ray, you will see a smooth line because that dura mater is the border. So you'll see that there. So you have a subdural hematoma is another one. And this is a hematoma that is a venous bleed between the dura mater and the arachnoid mater. It usually also leads to the formation of a hematoma inside. So this is going to be something inside the dura mater because of forces. You tear a venous part, and so you have the dura mater here, and then you have the subarachnoid mater here, and so you're going to get the bleeding inside that area. Your intracerebral hemorrhage obviously is inside the cerebrum, inside the brain. It's going to be a lot of times an AVM, arterial venous malformation. More or less, this is a stroke. It could be caused by trauma, could be medical hemorrhagic stroke. So your traumatic brain injuries, obviously you have bleeding within the cranial vault resulting in the hematoma. We've already talked about the epidural, which is between the skull and the dura mater, the subdural, which is between the dura mater and the arachnoid mater, the subarachnoid, which is is between the arachnoid and the pia mater, and then you have your intracerebral, which is within the brain tissue itself. Now, moving outside of the brain, going to the face, we're not going to spend a lot of time here. But this is where I was talking about facial injuries can be very distracting and very discomforting. People will look, depending on what's going on, very poorly. And if you think about it, your face is kind of setting on the outside of that cranial vault. So people, and the example that I think of is someone that tries to commit suicide and they put the gun under their chin and they fire up and they don't kill themselves because the bullet never penetrates the cranium. It goes through all the facial structures and bones, which is not a deadly injury as long as you don't have an airway compromise or bleed out from that injury. So they can be grotesque. They can cause significant issues with airway management, with bleeding. Facial injuries can be a struggle to deal with. So if you have any questions over this presentation, make sure to contact someone in member development. We'd be glad to help you with any further information you request. Anything that piqued your interest, I certainly encourage you to seek out further information on those things. Learn as much as you can. Specifically, when I was talking about MAP, I know that it's not fully covered here, but it's something I would encourage everyone to look a little further into. Again, if you have any questions, let us know, and we will be glad to help you. Thank you for your time.